Hi, welcome back. Today we're going to talk about participant recruitment. You've already had this in CLST 1371 to some degree. We're going to talk about it again in good clinical practice if you haven't already had that. And this is a very big part of every research coordinator's job, so it does deserve some discussion about the ethical considerations that have to be made when recruiting participants. So I just want to go back and emphasize again the difference between medical care and clinical research. In medical care, the goal is always the individual patient. So the idea is to make them better, improve their outcomes, minimize their symptoms, but it's for the individual patient. The ethical principles there are therapeutic beneficence. So therapeutic beneficence, right? So this is the doing good, so that the actions that are taken are for the benefit of the patient. Therapeutic non-maleficence then is sort of the opposite side of that. It's the flip side of the beneficence coin. And this is the do no harm principle. At the very least, you won't harm the patient. And any new knowledge generated is incidental to the primary goal of therapy for the individual patient. Yeah, knowledge can be generated. There are lots of ways that knowledge is shared based on medical care, but knowledge is just totally secondary. It's incidental. So the goal in medical care is the individual patient. Clinical research then, the goal is new and generalizable knowledge. That can be used across a population for a large group of people. Ethical principles in clinical research involve autonomy, that's self-agency, the ability to decide for oneself the best course of action. Non-maleficence again, no harm. And then the justice aspect is balancing the risks and benefits, right? And we'll talk more about justice when we talk about vulnerable populations. And the therapeutic benefit to the individual is always secondary to creating knowledge. Now, individual get therapeutic benefit, that's awesome. People are super excited about that. That is a good and wonderful thing, but that is not the goal. The overriding goal is creating knowledge. So, undue influence can exist in between clinical research and medical care, and the conflict always arises when the physician and the investigator are the same person. Physicians, in their capacity as doctors, have loyalty to patients. Nurses have loyalty to patients. Everyone who's providing health care has a primary loyalty to the individual patient. Researchers have a commitment to research and creating and generating data. Then it gets really confusing, and the question becomes, is it ethically acceptable for a physician to recruit an existing patient into a clinical trial when the medical doctor is also the principal investigator? You will find this to be very common. There are many private practices that also have clinical research trials, and it becomes very confusing for the physician, to be quite honest, as well as the patients, to really be able to clearly see the difference when that patient and that relationship with that medical doctor changes from clinical care to clinical research. It is confusing for all of the parties. Now, I don't think it's necessarily ethically unacceptable. However, I do believe that situation generates confusion and questions, and it requires a special amount of consideration to handle well. Let's talk a little bit about confidentiality and privacy. Confidentiality is the right to choose how your personal information is shared. You sign a confidentiality statement regarding your protected health information every time you see a physician, right? You go to their office and they want to submit information about your visit to your health insurance. Right, that's your confidentiality. You have the right to determine whether you want your health insurance plan to see that information. Breaches occur in confidentiality when your information is disclosed by a treating physician to a party outside of the therapeutic relationship. If I say no, I don't want my information from today's appointment to be shared with my healthcare plan, and someone in the billing office accidentally submits that information to my healthcare plan. That is a breach of my confidentiality. I've asked them not to share it, and it was shared. So that therapeutic relationship, you have to understand also, will include other physicians. If my doctor says, I want to refer you to another specialist, and I say no, then my physician should not discuss my care with the specialist. However, if I say yes, and my doctor calls and speaks to the other specialist, that's perfectly reasonable because I've agreed to it. So that confidentiality gives me the ability to determine who is going to have my information. And some more examples of confidentiality breaches in regards to recruitment. Reviewing individual medical records or database to determine eligibility without the patient's knowledge. It would not be okay if I was a clinical research coordinator in a private practice that also performed clinical trials. It would not be acceptable for me to look through the records of people that are seen in the private practice for the purposes of trying to recruit someone. A workaround for that, because that is breaking confidentiality and how that person determines who will see their information. So the workaround for that is, in my case of my pulmonologist, I go to see her. I have not participated in clinical trials, but I am always curious to see how sites manage their clinical trials. So every year they ask me, can we look at your records and determine if you're eligible for a trial? I always say yes. In that case, then they are not breaching confidentiality in my case, because I've told them they can look at my records and see if I'm eligible for something. Another example of confidentiality breach then is talking to people. So you say, okay, Heather, I understand I'm not going to look at the medical records, I'm not going to look into databases, but I am going to sort of maybe ask around other practices. Hey, if we have a study for a new drug for heartburn, you see a lot of patients around here with heartburn. You're not only breaching that patient's confidentiality, but you're asking the other staff to do as well. So you're sort of widening the circle of breaches here. So what is privacy? Privacy is different than confidentiality. Confidentiality is my ability to determine how my information is shared. Privacy is just leave me alone. It's the right to be left alone. Breaches occur when a party outside of that therapeutic relationship interacts with a patient for recruitment purposes. Some more privacy breaches is performing any research procedures prior to obtaining consent. You are not respecting that individual's autonomy if you are in fact screening them. A good example would be I'm at my pulmonologist's office. I have to get some blood work drawn, and they decide to draw an extra little blood work to see whether I would be eligible to participate in a clinical trial. That blood work is done not for my own individual care. It is done exclusively for the purposes of looking at eligibility and potentially recruiting me. In that case, they have breached my privacy because I have a right to be left alone until someone is asked. And essentially with privacy, I have to invite somebody in. Contacting potential subjects for recruitment without their consent, right? So just to sort of reiterate, confidentially, the right to choose how information is shared, and privacy is the right to be left alone. Anybody who's had to go to the do not call website and put their telephone number in there so they don't get a lot of telemarketers understands the privacy situation. So we're going to talk about some recruitment tools, direct advertising, and incentives. Incentives we're going to spend a lot of time talking about because these can be very dicey in terms of treating people ethically. In terms of direct advertising, we have said this elsewhere, I think in 1371, and the FDA has said this, quote, direct advertising for study subjects is the start of the informed consent process. So the FDA expects information in direct advertising to be very clear and not misleading. Sometimes direct advertising may be part of the origin of therapeutic misconception. And advertisements often appeal to those in need of medical care rather than people who want to be individual contributors to research. This is how the ad will go. If you watch daytime television on Fox, there seems to be an abundance of clinical research advertisements. And it'll go something like this. Do you or someone you know suffer from bipolar disorder? Right, so those are the people they're looking for to recruit for a trial, someone with bipolar disorder. But it already makes people think, yes, I have this problem, and so this can create a little bit of confusion, right? Because now they're reaching out to me based on my diagnosis rather than saying, we are looking for people to contribute. Now you'll see both of those kinds of ads, but the ones that start off, we are looking for individuals to contribute to participate in a clinical trial, and then discuss it. So it's sort of the timing and of the wording and the words that are used. Now incentives are a totally different story. So you're oftentimes going to find trials that use incentives as well as direct advertising. But incentives are anything of value that is given to a participant just because they were on a trial, right? The only reason they get it is because they participated in a trial. If my pulmonologist stamps the parking ticket of everybody that comes into her office, whether they are getting their own medical care or if they're participating in a clinical trial, that is not an incentive because everybody's getting that. The idea behind incentives is really to help you with enrollment. And the incentive recognizes this is the burden of participation. Incentives are not a benefit. And a volunteer is a person who performs a service willingly and without pay. In the beginning of the semester, we talked about different words for people who participate in a trial. Volunteer is oftentimes used, but if you're using incentives in an effort to increase the recruitment and enrollment, volunteer is probably not the best word to use because it does sort of imply that there will be no pay and that they are doing this just because they're a good person, right? So we have to be careful using the term volunteer around incentives. Now, there is an exception we'll talk about in a few slides. So different recruitment models. The market model, we're going to talk about each one of these. The wage payment model, the reimbursement model, and the post-trial appreciation model. These are all common, and I'm sure you'll come across these depending on your sponsor in your research site. So the market model uses supply and demand as the primary drivers of how much compensation people are going to get. The bigger the supply, right, the lower the compensation gets to be. As the supply of participant dwindles and the demand goes up, the compensation will change. This can be very helpful in attracting participants, and you've probably seen these advertisements. We're going to give you $8,000 to participate in a clinical trial. That is a trial that is going to have a lot of demand on that participant's time, and therefore the supply is going to be low, so they're going to be willing to give more money to attract participants. In poor populations, this can create undue influence. If you were to say to someone who lives on Park Avenue in New York City that you're going to give them $8,000, they'd say, oh, no, you're not going to give me $8,000. But a college student oftentimes would say $8,000 is great. And so the problem with the market model is that it can create sort of some injustice in terms of who it attracts. And to this end, it encourages professional guinea pigs, people who do nothing but participate in clinical trials. And I have a link to an article about professional guinea pigs in the module. So the market model, the focus is supply and demand. The idea is it's going to improve the speed of enrollment. And the advantage is it can give you very rapid enrollment. And the downside is that it incentivizes people to become professional trial participants. And when they become professional trial participants, you're increasing their exposure to risk. The wage payment model is a little bit different, and it sounds really good. The incentive is based on the fact that the participant is being paid as unskilled labor. You're going to give everyone blank dollars per hour. You're going to pay them for their time, and you're going to treat them as unskilled. And this would standardize payment across all studies. So the research site, for example, can say everybody's going to get $10 an hour for the participation in a trial. So that pays them the same across all studies. It reduces or eliminates the supply and demand concept. This doesn't necessarily do anything to the speed of enrollment. So it is sort of good because it can, by paying everyone the same wage, it can reduce the likelihood that you would be targeting vulnerable populations a little bit. You can still have that problem with poorer populations. So the lower the dollar per hour or dollar per day payment is, the more likely is you're going to then tempt people who are poor to participate in the trial. It can also create professional guinea pigs depending on how much that wage is. Is it a living wage? And if it is, then you can ask people, you can inadvertently create an environment to entice people to do this for a living. So in the wage payment model, the focus is, and the concept is, that the participant is unskilled labor. It doesn't do anything to enrollment, and it can still represent a profit to poor individuals. And so the disadvantage, I think, is pretty significant. The advantage then is it standardizes payment across all studies. So that's sort of the downside to it. Creates the neutral speed of enrollment. The reimbursement model says we're going to pay participants monetary expenses for their involvement in participation. So the monetary expenses could be transportation, it could be lodging, it could be anything like that that offsets what the participant has to put out in order to be there. The idea is this eliminates undue influence for the vulnerable. Everyone is getting their transportation expenses covered, whether it's subway tokens, cab fares, Uber expenses. Everyone is getting the same compensation, and it's not significant. It basically says we're going to give you some money to offset whatever you have to pay out of pocket to participate in the trial. So there's no real advantage there. You're not getting people that are participating because they're going to make a lot of cash before Christmas. It also does nothing to the speed of enrollment, really. It does not draw people to the study. People are not intrigued by the fact that they're going to get taxi fare or subway tokens. Payments for time may be different for participants, but revenue neutral for all. In this term, if you do pay people for time, because they are spending time there, the payments may change for individuals, because if someone's on a trial for longer than another person, they will earn more money just because they have participated for longer, but it's going to be about the same for everybody in terms of they will all be compensated the same for their time. So the reimbursement model covers only incurred expenses. It's also neutral in terms of how much does it entice people to participate in the trial. So it really doesn't do anything to speed up recruitment, but the advantage is it eliminates undue influence. And again, we're going to talk about economically disadvantaged individuals, later on, but you could still have the opportunity of representing some benefit to very poor individuals. And then the post-trial appreciation model. I like this one, but it's not terribly common. And what it does is it gives participants a token of thanks at the end of the trial. If it's not announced, and therefore not really an enticement, it doesn't do anything to the speed of enrollment. And if it's not announced, basically there is nothing given to the participants until either the study is done or they are done participating in the study. This is true volunteerism. You could call somebody in a post-trial appreciation model a real volunteer, because, especially if it's not announced, because they are not doing it for any ulterior motive. And how much you give someone is sort of a tricky thing to say here. How big is the token of thanks? Do you determine that based on how long they were on the trial? Is it a coffee cup? Is it a trip to Las Vegas? I mean, you could have a huge spectrum of rewards that you think would be appropriate to give And that's really hard to define, and it's going to require a lot of help from your IRB. So in this one, reward is given at the trial completion. If it's hidden and not talked about, it does nothing to the speed of recruitment. If it is discussed, it could theoretically possibly improve the rate of enrollment. The advantage is that it does reward true volunteerism. And if it's hidden, it eliminates all influence because it's just a surprise at the end. Some of the downsides to the post-trial appreciation, it is very difficult to determine how much appreciation to show, and sometimes IRBs will have trouble with this. Sometimes IRBs will overlook it. You may or may not have a lot of feedback from the IRB to help you figuring this out. So here, these are the 4 models, and here are the good and the bad things to think about each one of them. Here are the references again, our textbook, the dictionary. Please let me know if you have questions. I love them. I love to think about them. I love to answer them, and I hope you have a good day. Talk to you soon.